Hi, my name is Stephen Trevick. I'm a neurointensivist and the head of the Neurocritical Care Society Ethics Committee and a contributor to the Neurocritical Care On Call ethics section. Today I'm going to go through some common questions and concerns that can come up around some of the topics we discuss in that section. So to start with, we talked about the principles of neurocritical care, of medical ethics and neurocritical care. And I think one of the biggest questions comes up with, well, perhaps the biggest question in most of medical ethics is how to balance those principles. As is mentioned in the chapter, sometimes people say first, do no harm. But non-maleficence is only one of those four. And the point is, in ethics, there often are different ways to balance them. Sometimes autonomy, well, most commonly autonomy and beneficence come at odds when a patient wants to do something and so we want to support their autonomy, but we feel like it would not be best for them, and so it goes against our beneficence. And the point is that they're difficult, and there's a lot of different patterns and manners by which to do it. Sometimes we rank how drastically you're going against the principle, and that is a principalism sort of approach. But again, it doesn't tell you greatly how to balance them if it seems more similar. Sometimes we talk about consequentialism, which is what the likely outcome will be, and see if we can balance them in that way, but that does tend to favor a more beneficence model, which may be called paternalism. And it's really the struggle to balance them when they are apparently opposing that makes it medical ethics, and that ends up being the thought process. So we usually don't come out with one answer in medical ethics, but I suppose that that's true in a lot of medicine. Two other principles that are discussed a little bit less commonly. There's the four that are most common, what's called the Georgetown Doctrine, with autonomy, beneficence, non-maleficence, and justice. The two others that are on different lists added on are truth-telling and respect for persons. And those can fit into the prior four, but are often popped out because they are so important to the principles that are stated before and to our cooperation and respect within society as physicians, so that people are comfortable telling us things, people are comfortable trusting us, and people feel like we are there to help humans get better and be healthy. The next one we talk about is post-intensive care syndrome, in particular the emotional aspects of it and as it relates to families. Perhaps the hardest question is really how to identify it, because there are so many different symptoms that can come up after being in the hospital. It's often explored around PTSD, post-traumatic stress disorder, which seems to be similar in some ways. PTSD seems to be a problem of memory, where you cannot recall the episode without re-experiencing the emotions. Sometimes that can be a positive experience, like the birth of a child. Whenever you think about it, you feel like you're there. But more often we think of it in terms of traumatic exposures, like violence or army, assault, things like that. And those memories do seem to follow the same pattern as some of the memories from watching a very sick relative or yourself in the hospital, particularly in an ICU setting. But there's definitely some ways it's different. Obviously, the types of risks involved, the types of experiences are very different. And it probably doesn't catch all of the types of symptoms that people can have after a hospitalization. It's our working diagnosis and really falls into the realm of psychiatry, which is still working through some of those diagnostic measures and categories. And so we're continuing to work on it. Often complicated grief is another diagnosis. Sometimes people just go with depressing or anxiety symptoms, but that work is ongoing. I think the most common question I get about breaking bad news is how to make time for it. about how to make time for these difficult conversations we have. And that's obviously difficult, and it's different for each person. What's most important is managing those time expectations. I think having really intense and very present conversations ends up saving time in the long run. They don't keep asking you back if you can really make your impression directly. Not always, but often. Giving time for silence, speaking slowly and clearly, and giving really just even a few seconds of complete silence with families and patients, if that's what they need. It may only take you a few seconds, it may feel very slow, but it saves minutes and hours of more difficult discussions when they really feel your presence there in those moments. Talking about cognitive biases, I think one of the hardest parts about it is any one of our biases, any one of our errors has a great deal of inertia. And we get stuck in a certain thing. We are supposed to be professionals, and we are supposed to be the experts. And one of the most difficult things is how to discuss, how to confront the bias. And I think one of the greatest things about studying all the different cognitive biases and all the different ways that we make these sorts of cognitive lapses and oversights is when you can understand those types of errors and you understand how pervasive and innate to humanity they are, that you're then more comfortable and prepared to confront them and to admit them. Admitting to yourself, admitting to your colleagues, admitting to family members and decision makers that you were thinking about things one way and you've now thought of a different way. That, yes, now I realize this is important, independent of whether you should have or could have thought of it somewhat before, allows you to not continue to go down the wrong path. And is the most important part. It's not a loss of professionalism, but a gain when you're able to identify that you've thought of something better, that you've found another way to do it. And to maintain that flexibility is going to be the way to have the least damage from the cognitive errors, the cognitive biases we are bound to enact. The most concerning part, I think, about talking about unbefriended patients that people come up is what's the end point? There's a lot of important things we can do along the way, and we very much should. Some of these can include trying to get collateral information from whatever sources they are, even if that person cannot act as a surrogate, even if the paperwork doesn't really guide you the whole way. And the point is that different governing bodies have recommended different things. The recommendations from the American Geriatric Society are different than the ones from the American College of Physicians. I believe the SCCM has a recommendation, and they're somewhat different. State law can lead us in different directions, and people don't always follow these things. This is one of those things we run into ethics where we find we may have the recommendations that are pretty well thought out, but it's not always what people do. Most of the recommendations at least suggest for major decisions, anything that isn't emergent, like an emergent surgery, to at the very least go through the ethics committee, but preferably to get a guardian. However, state by state, the laws are different. Sometimes guardians are much harder to come by or can take a lot longer to get. I think it's very important to at least involve the ethics committee, to have more people involved. And it's one of those great cases of, never worry alone. When you have a patient who, as we say, is unbefriended, somebody who lacks a surrogate or power of attorney making decisions for them, to have more people involved, to have other physicians to bounce it back with, I think is not only important that you'll make a better decision, that you'll balance some of the cognitive biases or ethical biases that you may have, but will allow you to recognize how important that is and how many different ways there are to approach any major decision making, including those very difficult patients. With undocumented patients, I think there's fewer questions. It's often, from an ethics perspective, it's more of a practical concern of how do we bring these patients all the resources that we'd like to, that they deserve, when those resources may not be available, when our standard social safety nets are not available to those patients. And this is often much more of a difficult social work issue than ethical. Though the ethics are important to drive us to continue to give that time, to give that energy, to get what we can for our patients. Perhaps something where ethics can be very contributory is in engaging, giving us the tools that we need to engage collateral, to engage family. And by having a good grasp of what our roles are as physicians with patients of any documentation status, of any immigration status, and communicating that clearly to families. I think sometimes we want that to be implied. Sometimes we hope that people would just know that from us or trust us. But they have no reason to, and they may not have had experiences with any variety of social programs that should make them feel safe or comfortable or trusting. And so to be very clear, we will protect you in these ways. We will keep this and this, and keep your data protected from these various organizations. We don't report to immigration. We don't report to this or that. And to express your desire as a physician, as a care provider, to get the best treatment available for this person. And to really focus on that. Using that language can be very helpful to engage family members and other members of the community to be able to mobilize resources and be able to get the best care for these patients. Ethics consultation is very different place by place. What's available, what sort of ethics committees are available and what they can do, how they're empowered, who's involved in them, and how much time they'll contribute is very different place to place. Some institutions have more robust ethics committees. Most large hospitals should have ethics committees, but they don't always, or they may not be very developed. But universally, I think people have a lot of trouble figuring out when to call ethics. I can tell you, as somebody who has performed a lot of ethics consults and deals with our ethics committees quite a bit on a number of ethics committees, a lot of the calls we get maybe aren't for us. Or what I mean to say is we will direct people towards other resources. A lot of calls to ethics, maybe the only contribution ethics can have is to say, this is really a question for palliative, this is really a question for risk management, this is really an administrative question. Very often we ally with those specific groups or some more, and we all work together. We have to have different positions. When I myself will only see somebody as a neurologist, as a psychiatrist, or as an ethicist. I can't do 2 or 3 of those for one person. So we all have our own contributions. Even if we have a thought of where somebody else would go, we need to have somebody else engaged in that position to make certain that all the aspects of somebody's care are taken care of. So that's all a way of saying, be broad. If you're not certain, call ethics, and maybe they'll help direct you towards somebody else, or maybe they'll be able to provide that support. Not only can they help clarify the issues and really set it down, but provide support for the moral distress that can be surrounding a lot of our patients and really contributes to burnout and dissatisfaction amongst healthcare providers. A lot of questions are simply based around when two reasonable stakeholders, meaning physicians, nurses, care providers, and or family members and patients, seem to be at conflict, and it's not clear how to balance those. It's not the only part. I'd say if anybody on the team at all feels like somebody's not getting what they should, or there's a barrier standing in the way of getting people what they should have, that's a time when ethics can be involved and help clarify things. And I just wanted to put in at the end a statement which I hope is clear throughout this, that physicians are one member of, or one group of members of the care team. But when it comes to medical ethics, it's incredibly diverse, and all sorts of people, particularly bedside nurses, but also NPs, social workers, physical therapists, every other member, not the least of which including also administrators, get really involved and have voices. And there's relatively little from a truly ethic perspective that is really specific to one part of the care team. We all have to work together to make certain that we're providing our patients the type of care we want to, and to support that, which at the end of the day is what medical ethics is all about. Thank you so much to everyone, and I hope you continue to learn from this. Thank you.